this meta-analysis is getting a novel approach of stimulating eggs and getting more numbers of them. And I must say that women exhibit at least 2 to 3 waves of folliculogenesis during the same menstrual cycle. And I would start by the words of John Major, the previous Prime Minister of the United Kingdom, who says going back to basics is the start of everything. Going back to basics, we all know that the ovarian stimulation go from the quiescent stage to the mature stage in really over 100 days. And during the 100 days, we have 85 days, maybe 85 days as non-hormonal dependent. And for the last 15 days, the follicles start responding to hormones and produce to produce the maturity process in the follicles. And by this, no one would say that at the beginning of the cycle, all the available follicles would be ready for maturity or getting in the process of maturity. Some of them would be still in the quiescent stage, or maybe will take up to the beginning of the luteal phase to start responding to hormones, either exogenous or endogenous. And that's why the concept has really started back in 1951. So this is not a new concept. But lately the interest in this in the multi-wave folliculogenesis is getting more towards acceptance, because embryological advances, especially with regard to the blastocyst culture, aneuploid testing, and vitrification protocols have opened a new thinking of why don't we start stimulating in the late part of the cycle rather than at the beginning side. So we'll be talking about the luteal phase stimulation, and not in addition to that of follicular stage stimulation. And this has started what we called, everybody knows it as Shanghai Protocol, which they started after the retrieval of the first cycle of the first stimulation, they started again 3 to 5 days after follicular aspiration to start stimulating the eggs again. And let's see first who are the cases that are indicated for what we call dual stim. Dual stim means the dual stim, dual stimulation, follicular phase stimulation and luteal phase stimulation. Of course, those of advanced maternal age, poor ovarian reserve, previous poor ovarian response, and in time-sensitive conditions like ovarian cancer, imminent chemotherapy, imminent oophorectomy, gonadotoxic therapy. In these cases, time is very sensitive, so we're trying to get the best number of eggs during one cycle. Of course, we have, one would argue about the healthy, are the eggs coming out or the oocyte coming out from the luteal phase are healthy or not. That's why we're going back into to see if it is visible or not. This is systemic review discussing if what is the true place for double stimulation and double oocyte retrieval in the same cycle for patients diagnosed with poor ovarian reserve. A systemic review including a meta-analytic approach. We must admit that they just say poor ovarian reserve, and they did not say confined to Bologna criteria. That's why during my presentation, it's not only confined for those who Bologna criteria are applied upon, but rather on a heterogeneous group known by being poor ovarian reserve. The study involved 5 prospective studies and 6 retrospective studies. They looked into the primary outcome of the number of oocytes and the number of M2s, which are the oocytes that have reached maturity enough to inject them with the sperm or to fertilize them with the egg, fertilize them with the sperm. Secondary outcome includes day of stimulation, cycle cancellation, which is terribly important. We have many, many cycles that we cancel because there is no enough follicles that came out. And I would say enough in between two brackets, because some would consider one oocyte or one follicle is not enough. Some would consider anything that would come out would be viable. Cycle cancellation, they're looking into fertilization rate, blastocyst formation, and of course, clinical pregnancy rate. When we deal with this statistical analysis, they've looked at comparing between the follicular phase stimulation versus luteal phase stimulation. They're taking the eggs that coming from follicular stage and compare it with the luteal phase. And from another approach, they've taken all the eggs that coming all through the cycle in what we call duostim versus conventional stimulation, which means that only dealing with follicular phase stimulation. And of course, we have to admit that we're not dealing only with poor ovarian reserve, but some of these studies have looked into mixed population that are producing lower number. So let's start with the follicular phase versus luteal phase stimulation. That included 9 studies, 4 prospective, 5 retrospective, and the sample size is quite pulling all these cycles together. We're talking about 1,026 in the follicular phase in comparison to 988 with that of luteal phase stimulation. I must admit that the heterogeneity in between studies is quite vast and huge, because some of the studies have stimulated with only mild or minimal stimulation. Some has used only clomiphene citrate or letrozole. Some have added up FSH or HMG, and they've triggered either with gonadotropin-releasing hormone agonist versus HCG. On the other, and what they have found that the stimulation date, there is no statistical difference between the two, 3.9 to 10.2 with regard to follicular phase, luteal phase 8.7 to 10.8. So we're talking about no statistical significance in between the length of the stimulation days. Cycle cancellation rate,
Hello?
again, there's
understanding of a course. You may know that we've been thinking about this for quite a long time. And in fact, we'll still be arguing about these questions after the second coming.
Who is talking?
Because there's no answer
Hi,
to
Husam.
those in an
Hi, Ya'qub, how are you doing?
Not bad.
Listen,
I want to create a new college
there's somebody talking.
in a traditional way. This is a very difficult
Oh, sorry.
No.
It's my fault.
to overcome. But if I just look in the other direction and say, we want to have Clay Christensen University to be a module.
Sorry.
It's okay.
Can you hear me now?
Ya'qub.
Yeah.
Okay, great. So again, we were talking about analysis concerning comparing follicular phase stimulation versus luteal phase stimulation. And as I've said before, it is quite a heterogeneous population, because they included some of them that would Bologna criteria would apply upon, and there's other group that only are producing lower number of eggs in the previous cycles, so they've included N. With regard to stimulation protocol, again, it is quite heterogeneous stimulation protocols, starting from mild or minimal stimulation. Some are using only clomiphene citrate or letrozole. Some have added up FSH or HMG. Some have used antagonist protocols. And they've, with regard to the triggering, they've used either GnRH or HCG. They have found no statistical significance with regard to stimulation days. Not even in the, again, it's not statistically significant with regard to cycle cancellation rate. And with regard to the luteal phase, the number of oocytes retrieved, they have found that out of extracting the data, that the number of eggs or oocytes is quite higher in the luteal phase stimulation in comparison to that of follicular phase stimulation. And again, looking into the number of M2s, they have found quite significant difference between luteal phase versus that of follicular phase stimulation, and that's out from looking into some studies. However, when they've looked at the pooled data, they have found no significant statistical significance with regard to the number of M2s. When we look at the embryological data, we cannot really take it as pool studies because not all of them have unified what they're looking at. Abaldi from Italy have found no statistical difference with regard to the number of fertilized eggs, number of biopsied blastocysts, the number of euploid blastocysts, or the quality of the blastocysts from the morphology. Again, they've looked into the day of blast duration. Again, they have found no statistical difference. However, some others have found that better embryological data coming from luteal phase stimulation versus that of follicular phase. Again, no statistical difference was found with regard to the fertilization rate of in comparing between the two stimulation protocols. Looking into the clinical pregnancy rate, it was ranging between 10.7 to 85.7 when we, with regard to that of follicular phase, in comparison 20.6 to 75, and the meta-analysis pooling data have shown a trend towards, I wish I can come in your place, Ya'qub, anyway.
No, a colleague of mine knew that I'm doing this, so she wanted to join me. Okay, keep going.
Of course, welcome. So the pool data showing a trend towards better clinical pregnancy rate in luteal phase support and luteal phase stimulation. And some group analysis, the very poor ovarian reserve showing better results in luteal phase stimulation versus that of follicular phase, but that has not been found in the mixed group. When we're looking into the live birth rate or ongoing pregnancy rate, the pooled data have shown no statistical significance with live birth rate or miscarriage rate, and with regard to the consolation rate, the results are quite conflicting. Now, if we take comparing the dual stem versus conventional stimulation, so in the dual stem, we're talking about the outcome out from 2 stimulation in 1 cycle rather than the usual conventional stimulation. They've looked into 5 studies, 5 retrospective, 1 prospective, and in this part of meta-analysis, they've pulled 342 cycles where dual stem were used versus 412 with regards to the conventional stimulation. And again, there is no consistency in the inclusion criteria, and vast variations has been found in all the criteria they've used. I just want to elaborate to some of the studies with regard to stimulation protocols, like that of Corduzo. They've used the conventional antagonist protocol using recombinant FSH and LH, and they use recombinant human HCG for their triggering. And in the second part, they've just repeated the same stimulation that they have found in the that they've used in their follicular phase. Looking into the cycle cancellation with dual stem, it was 13.1 to 18% versus 28.7 versus to up to 37%. So it is quite significant between conventional and dual stem for the advantage of dual stem, less cycle cancellation. Looking into the number of oocytes, again, it was significantly different in favor of dual stem, achieving 5.8 up to 8.8 oocytes versus only 2.3 to 6.7. Looking into the pooled data, they found statistically more oocytes were dual stem in comparison to that of conventional stem. Concerning M2, the number of M2s, again, the pooled data have shown that we have more M2s, we have significantly more M2s with dual stem more than conventional protocol. But again, not all of the studies have shown that, and this is out from the pooling data. Pooled data, yani they've gathered all stimulation cycles from all the studies, and they looked into what they have found at the end. And with regard to the embryological data, not all studies have reported it. Again, I go back to the Corduzo study. They have found no statistical difference in the euploidy data, either from the number of biopsied blastocysts or the number of euploidy embryos. So although we have more M2s, but we have not found, not we, of course, Corduzo et al. Have not found that the number of eggs is reflected in the euploidy rates, but they have more euploidy rates for sure. With regard to Louis et al., but we have to remember, of course, that Corduzo study includes only less than 25 cases, so it's not a big study to start with. Louis studies, using again dual stem, they have found significantly more fertilized oocyte, cleaved embryo, and top quality embryos. Mortazanova study again have shown significantly higher number of blastocysts. With regard to the fertilization rate, no difference. Pool data to look at the pregnancy rate or the live ongoing or miscarriage rate, again, no statistical significance. Now, so looking into the whole meta-analysis, one would say that the use of this phenomena of multiple ovarian waves during the same cycle have yielded to more oocytes, more M2s, the same percentage of euploidy embryos, and they suggesting that it is something of should be looked more, and more studies have to come in to show the same results, because the dual stem have increased the number of oocytes, the good quality embryos, and the potential of increasing the percentage of live birth rate. Yielded oocyte from the luteal phase seems to yield higher number of oocytes of M2s, and the available embryos that were also found to have the same rate of being euploid, which is something quite reassuring for those who will try to use dual stem. Of course, the problem with the meta-analysis, as they have clearly elaborated, that the heterogeneity between the studies, especially with regard to the stimulation protocol used, and we can conclude no safe conclusion with regard to which protocol one should attempt, because none of them have used the same protocol. Again, the limitation, one other limitation of this meta-analysis, that the number of studies is quite low, the number of cases is quite low, and again, we are exposing our patients to prolonged exposure to gonadotrophins. Of course, one would argue that in these, yes.
Can we start discussion with others? For we are presenting the data for around 20 minutes now, and the audience may not follow up all these data. So okay, can we start on focusing on discussion?
Okay, I would just conclude that dual stem is a potential tool that may assist towards achieving improved outcomes using multi-wave follicular genesis. Let's start discussion. So now we have another paper that just came out from Fertility Sterility of January 22, coming from the Al-Baldi group from Italy. Again, it just says exactly the same thing, and showing that, elaborating also that the drop rate that happens in these cases can be much improved by doing dual stem rather than conventional stem. Let's start with discussion. So shall I open it for you, Hisham, to start discussing?
Okay.
Actually speaking, I don't consider this meta-analysis is a reliable source of evidence. You can check first the duration of between receiving and accepting this meta-analysis. It took less than 2 months duration, and for meta-analysis systematic review, this duration is too short for it, for reviewing, for rewriting, for reappraisal, etc., etc., etc. Second, actually this meta-analysis is mixing apple with orange. It makes retrospective studies with prospective studies. It has not included a single randomized control trial in this particular issue or this specific topic. The heterogeneity actually is very high, 0.002. Actually, the authors themselves describe that the risk of bias in these results are very high, considering it a very high source of bias. So you cannot rely on such data. You always try to build up conclusion based on sound evidence. In such topic, we can say there is a lack of evidence for such condition or for such topic. But it's so interesting that we can see a publication stimulation, but we cannot rely on such evidence. For me, at least, for practical reasons, we stopped using this protocol. I'm talking for now from actual or realistic practical life. We tried it for around 6 months, but we stopped using it anymore. The results are disappointing. Actually, cancellation rate is not small at all. Third, the cost is a major barrier for our patients, although we make a major reduction in the price for the second cycle. It's not free, of course, but this will cause a burden for injections, etc., for the patient. So for my only opinion, and it is just opinion, the dual stimulation is not a valid option for cases with poor ovarian response, despite that this meta-analysis or this systematic review actually present poor ovarian reserve and other infertility problem, which I was wondering why it was done in other infertility problem. Thank you.
Thank you, Dr. Hisham. I must admit that I've personally did not have wide experience in. I have used it for less than 15 cases, and we charge nothing for the second cycle. So we call it a package of dual stem. So we do with the same cost. We do the two stimulation, and as yet we have not transferred any of the embryos. We have done in around 6 cases we've achieved euploidy embryos, but we have not transferred any of these embryos back. So I cannot say that my experience would say that we encourage it or discourage it. Definitely, the meta-analysis is not 100%. Is not one we should not transfer to conventional routine work. But it's quite interesting, especially that we're talking about patients that are producing less than 3 embryos, so less than 3 oocytes. So it's quite interesting to see and discuss with the patient if they would like to pursue such research rather than such practice. Dr. Ya'qoub, what would you think, and do you have any experience with that?
Why don't you let the discussion run a little bit longer? Don't you have other people on the line online?
Yeah, Dr. Muhammad Yahya want to comment.
Dr. Muhammad Yahya.
Please go ahead, Dr. Muhammad.
Assalamu alaikum. Actually, before starting discussing this issue, I hope to identify or to provide a short notice for the participants about the difference between systematic review and meta-analysis. This is for the first thing. Number two, as Professor Hisham said, this meta-analysis is very, very weak, and the authors admit that in their figures and their discussion. And actually, we used this protocol in our center here in Egypt, in Sohag, and we found a very high cancellation rate and very disappointing results. And we stopped using it at all. And we want to. We will discuss this practical issues at the end, but I think this is a research group also, and we have some young doctors with us who may not be aware about the difference between this type of studies. So I hope that one of our professors just elaborate the difference.
Your internet connection is unstable.
We hear you, Dr. Hisham.
Okay, thank you, Dr. Muhammad Yahya. And I would like to invite others to share their experience or share their views about this meta-analysis.
وديت هشام فين يا حسام؟
أنا أقدر أوديه في حتة، بس هو كل مرة كده لازم يبقى الإنترنت عنده فيه حاجة. أنت طبعا ده نص ستيبل يا عم، أنا فاهم.
يعني أنا شريك من بيتنا، يعني ما إحنا على حساب الحكومة. Okay, anybody else would like to comment?
دكتور هشام معانا تاني اهو.
Any other comment?
دكتور محمد يوسف عايز يعلق.
هو بس انا تعليق بالنسبه للديول ستيميوليشن، يعني هو فكره كويسه طبعا وماشي مع الفسيولوجي، لكن تطبيقه العملي بالنسبه لنا على الاقل حتى عندنا في مصر هنا، يعني كتير من الاستاذ المنشور عليه قالت ان هو كويس ونفس النمبر اوف اوسايت والكواليتي والاويبلويد امبرس، كل الحاجات دي بتقول ان هو كويس، لكن تطبيقه بالنسبه لنا انا حاسس ان فيه مشكله، بمعنى مين العيان اللي نعمله فيه؟ هل فعلا البول ريسبوندر هم العيانين اللي يناسبهم كده ولا؟ انا اعتقد العكس، يعني ممكن عيانين هم يعني جود ريسبوندر يناسبهم كده لو احنا عايزين الوقت هو مشكلتنا واحنا هتاخد كيموثيرابي او كانسر، لكن البول ريسبوندر بالذات مش ده اللي هيحسن الاوتكم فيهم، بالذات في مصر عندنا هنا العيانين بياخدوا ادويه كتير، بيدفعوا ثمنها، بيدفعوا ثمن التجميد، بيدفعوا ثمن التو سايكلز، كل الحاجات دي كوست، وفي الاخر النتيجه ما هياش المتوقعه او هي المطلوبه، النتيجه قليله جدا، الحمل قليل جدا في الاخر فضلا عن السايكل كانسليشن. فانا شايفه كريسيرش وايز هو جود توبيك، لكن كبراكتس او تطبيقه في هنا في مصر عندنا شايفه ما هواش يعني مناسب لينا قوي. فانا ما بفضلوش للنقطه ديت ان انا هدي العينه مرتين تنشيط واجمد وفي الاخر طلعت بويضه او اتنين زياده ونتائج الحمل قليله. برضو نقطه ان ده فوليكولار فيز وليتيال فيز دي برضو يعني انا مش مقتنع بيها قوي، لان معظمنا بيبدا بعد اليوم الخامس مثلا، بعد ما حصل يعني كومبليتلي تورس الكوربس لوتيوم، فده غالبا تبادل الفوليكولار فيز الجديد مش اللوتيال فيز القديم. فدي برضو نقطه يعني انا شايفها ما هياش يعني ما هوش بروتوكول مناسب للبول ريسبوندرز عندنا في مصر هنا اللي بيدفعوا الفلوس من جيبهم والمراكز بتدفعهم فلوس السايكل مرتين او حتى بيعمل ديسكاونت او بس في الاخر عندي دفع كتير في الاخر يعني. فانا عشان كده ما بستخدمش البروتوكول ده خالص، شايفه مش مناسب على مستوى التطبيق في عيننا وفي مراكزنا في مصر هنا. فده رايي بالنسبه للبروتوكول دوت يعني.
ممكن ارد؟ كان may I answer or comment؟
دكتور عندنا الدكتور محمود حسني ودكتور عصام رشاد عايزين نعلق.
اوكي.
دكتور محمود حسني.
دكتور محمود اتفضل.
دكتور محمود
السلام عليكم.
عليكم السلام ورحمه الله.
حضرتك انا في 2018 كنا اشرفنا على رساله MD بموضوع الديو ستيموليشن، وخدنا قرار في المركز ان نعمل كل عين فري، يعني الادويه كلها والسايكل الاولانيه والفريزنج كله يعني فري تماما يعني. فهو بصراحه يعني there is no improvement في الريزلت. احنا كنا بنجيب فعلا يعني مور اوسايت ويم 2 اوسايت اكتر، لكن الاوت كام في الاخر هو ذا سيم. وعملنا 10 حالات بس وقفنا بصراحه بعد كده، لان احنا لقينا ما فيش يعني هو بيردن على العيانه، حتى لو احنا يعني دفعنا فلوس من عندنا، هو برضه يعني بالنسبه للعيانه برضه يعني سايكيك بالنسبه لها، واحنا ما شفناش يعني ريزلت يعني افضل في قصه البول ريسبوندر دول بالذات. لكن هي النقطه اللي احنا اتكلمنا فيها ان هل فعلا في اليوتيال ستيموليشن ممكن ده هيغير الفسيولوجي اللي احنا متعودين عليه؟ هل فعلا في مالتيبل ويفز اوف ليكوجينيس بيحصل في ذا سيم سايكل؟ ده هيبقى على الاكاديميك ريسيرش، اعتقد ان هو ممكن يكون يعني مناسب هنفكر فيه، لكن على البراكتس اعتقد احنا يعني وي هاف تو ستوب ذيس براكتس لحد ما يطلع فعلا ايفيدنس ان في مالتيبل فوليكولار ويفز ممكن احنا نستخدمها في ذا سيم سايكل. شكرا.
دكتور عصام رشاد، وبعد كده دكتور طارق خلف الحسيني. دكتور عصام. دكتور عصام. اتفضل دكتور طارق. دكتور عصام شكله بيسمعني. دكتور طارق اتفضل يا فندم.
السلام عليكم. سامعني؟
وعليكم السلام.
دكتور حسام، دكتور يعقوب، دكتور هشام.
اهلا بيك دكتور طارق.
I have a question. First, is it physiologic to have follicular stimulation during the secretory phase or during second half of the cycle? This is one thing. In addition to the cost is quite considerable in our population. So one should be very, very careful in introducing any new modality with increasing the cost of the patient. Up to now, not proven to be effective, even by this meta-analysis with the small number and retrospective studies. So is it physiological first? And what about the costs? Thank you very much.
Okay, can I just ask a question?
Sure.
Of course, go ahead.
Okay, thank you. First, thank you to all حضراتكم for being here today and for the organizers, Muhammad Fawzi and the group. So actually, for the physiological concept, there are, to the best of my understanding, there are issues about whether the recruitment starts early in the follicular phase as waves or it's a continuous process throughout the menstrual cycle. So I think there is some grounds, physiological grounds for starting this way or for using the dual stem. But my question is, for this particular group of patients that they are working on, the poor responders, what difference would it make for waiting for a couple of months to start another cycle, for example? Plus, because if you are doing the freezing in women who give 2 or 3 oocytes, you are expected to have poor results, because actually freezing in those poor responders would give poorer results than for the average responders. I would understand the value of this for women who are nearly in kind of a crush in terms of time because of they have to start cancer chemotherapy, for example. But for the poor responders, I don't really think, she's poor anyway, I don't really think 2 months waiting for another cycle would make a huge difference. I would strongly add my voice to Dr. Hisham Al-Anani for what he said about the weaknesses of the meta-analysis, which are really very obvious and do not need further overemphasizing. Thank you very much. I don't know if my voice has been heard.
Yes, it was.
Very clear. Very clear.
Okay, thank you very much.
Thank you.
Dr. Ya'qub, you didn't comment.
I'm just waiting to, I'm just waiting to hear everybody, and then I give you my version on practical note. You covered all the points that I would have raised, but if I take you back, the concept of stimulation during an odd phase that we were not used to, like the luteal phase is currently being established. So much so that we have random start for patients who come for fertility preservation. They don't have time, you can start stimulation anytime, and you can get eggs and embryos. This concept of dual stimulation is originally being devised as a disparate situation that require disparate measure. For patients who are having fertility preservation and they have maybe a month before they start chemotherapy or radiotherapy, you can utilize the dual stimulation and any extra will be a bonus. Unfortunately, because we deal with poor responder and they are disparate group and we get desperate with them, people just clutch to this straw and they say, we can use it. In the European community, perhaps the approaches and the setting and the social norm is different. How? Yes, people might get disaffected by failing the first cycle when they are poor responder, and their resilience and their continuation with the cycle might be less, like it's been highlighted by Filippo Ubaldi and his group. Only 31% of patients who had failed cycle after poor response will continue to another one. So to improve this continuation with the treatment, they thought the do-stem will be probably an adjunct. So whatever eggs you get, but I think people, when they get enthusiastic about a new intervention, they massage it and they spin it in a way that is not credible. And what I heard, I believe, where people try to apply the same approach and they did not get the same results. And whilst I don't doubt Filippo Ubaldi and his group, this is a very credible and good and technically able group, but I draw your attention to the setting. This group have Laura Rienzi as their head embryology, and I see the setup and their cryopreservation result, whether it's for eggs or for embryos or for whatever, is second to none. So I believe them in saying when they get those eggs and they fertilize them and they're getting even percentages for the percentage of blastocysts that result from those eggs, like 1 in 6 of the eggs that they get result in blastocysts. And although I have a bone of contention with Filippo Ubaldi about the issue of doing aneuploidy of single embryo, that is nothing short of a travesty. I would never agree on it because you can only lose, you will never gain. But that is a sideline. So the concept is possible. You can get stimulation in the luteal phase. You can get response and you can get eggs, and there is no reason to doubt what is being produced by the so-called Shanghai Protocol, original, and then Filippo Ubaldi took up this and he has been reporting, and the last one, Husam, is what you referred to in fertility sterility, where he reported in nearly about 100 cases, but it's not randomized or anything. I think like Hisham said, it is too early and too little credible and homogeneous data to warrant doing meta-analysis. And like he highlighted, the time it took to review as an alarming signal, it's also no exaggeration to suggest that the journal that you have the meta-analysis reported in, it maybe had its good days in the past, but it's not the most discerning journal in the quality of the paper that it produced. I don't know what its impact factor at the time being, but I don't think it is hugely high. So if we take any message from this, do-stem is still an option for patients who are having fertility preservation and they have limited time before they start chemotherapy. It is not a situation, it is not a viable option, particularly in our setting in Egypt, where the cryopreservation may not be as good universally. It may be sporadically good, but not good for others. So the patient could end up being harmed rather than benefited, both financially and materially, with the material that she has. So all in all, I give you here at GUYS, we have one of the largest fertility preservation program, but we used it only sparingly. We use a random start, and it is reasonable, but we use maybe a couple of times, and my colleague who did that stimulation was not particularly impressed, but I have no reason to doubt Filippo and the other reports. So it's not for generalization, as my colleagues have already highlighted, for poor responder. It is to be used for fertility preservation when the freezing or the cryo program is really at quality and there are certain KPIs and it is reassuring survival, etc. That is as far as I can go. The cost effectiveness issue is also important, because if the patient is charged for 2 procedures, really, it is better to give her the full benefit of a follicular phase stimulation in 2 cycles rather than trying to cram under not typically physiological circumstances to have 2 stimulation in 1 cycle. But I'm happy to hear any comments from you about what I say.
Thank you, Ya'qub. You are, as always, concise the data and concise the findings and the clinical practice, as you always do. Let me start with saying, at the beginning of the antagonist protocol, it did not face that much of acceptance, especially that the short protocol was much less effective than the long protocol. But later on, with increasing knowledge about it and the learning curve start increasing, it has become the essential or the basic tool of stimulation of our follicles nowadays. So do you think that the difference with the results comes from the way that we're stimulating? Because not all the studies use the same protocol. Some starts day 3, some starts day 5, some starts with much more aggressive in the luteal phase rather than the follicular phase. So do you think it is a learning curve problem, or is it the physiology behind?
Anything has a learning curve, not just do STEM. So that is possible. But I'm talking about the concept. There are things that we introduce in medicine sometimes out of enthusiasm. I don't wish to, again, dwell on giving example, like using ovarian tissue to delay the menopause. How sad can you get? Okay, so these are concepts that are just adopted unnecessarily without proper thinking. This one, it could succeed, it may not, but it has always to take into account the setting. The situation in Egypt is not the same as in Italy or as in London. When it comes to the patient population, when it comes to the units, when it comes to the facilities, when it comes to the quality control, the cost effectiveness, all of that need to be taken into consideration. I would not jump into making those STEM is the answer to poor responder. Because poor responder, sadly, for all those who know, if you are including genuine poor responder according to Bologna criteria, you do not expect fantastic results. If you get 10% under any rate, you are doing extremely well. If you hear of anyone saying, in my poor responders, I get 25%, then either he is not using the right definition or he is not using the right statistics. And there is nothing in between. So that is the situation. When I go back to the antagonist, it is a shame that Hisham Al-Anani does not appear to be still with us, but right from the outset, good. Right from the outset, when it came to agonists and antagonists, there has been a bit of maybe marginally less result with the antagonist compared with the agonist. Of course, the learning curve may have bridged this gap a little bit, but I am a believer in the Human Reproduction Update review that Neil Slambalk has published. And he whittled down the use of antagonists. It is not negotiable for high responder, because you have not done everything possible to avoid hyperstimulation if you didn't use the antagonist. For the normal responder, because of the risk also of hyperstimulation, you should use the antagonist. But really for the low responder, it is still potentially advantageous to use the long protocol over the antagonist. And I have to be subjective here. It is my belief, for what it's worth, that for universal using the antagonist protocol, you sacrifice 2 or 3 percentage points with a success rate. If you wanted my theory about this, because the antagonist has a very narrow therapeutic range. If you give the patient 0.25, you probably get the right result. But if you give the patient double this dose of 0.5, you will have a nosedive with the implantation rate that has been demonstrated. If you compare this with the agonist, if you use 1 milligram, if you use half milligram, if you use 1/10 of a milligram, it does do the job without any impact on the implantation rate. So that could explain my subjective feeling, also what is being highlighted in Neil Slambalk review, and there we leave it. But it has advantage of being simple, being quick turnaround, being less side effect for the patient, being shorter in the duration of stimulation, using less medication if you are really doing the calculation. So everything has to be taken for its merits and then its disadvantage. What do you think, Dr. Hisham?
Well, for poor responder, as I guess, Neil didn't mention that long protocol is better than the antagonist for the poor responder.
But yes. You have the option of using it.
Yes, yes, of course. We had it yield more oocyte with the long protocol, and this has been proven even in the PRIMA study with Muhammad Yusuf that long protocol can yield more oocyte in poor responder. But the same result will happen, no significant difference in life per streak. But I agree with Neil that long protocol for normo-ovulatory can be more important than, or more efficacy than antagonist. Yes, but antagonist is much better, of course, in the higher responders.
Correct.
دكتور طارق عايز دكتور طارق عايز يدخل دكتور طارق خلف الحسيني وبعديه دكتور محمود جهاد. دكتور طارق اتفضل يا باشا.
السلام عليكم مرة ثانية. I'm sorry for the second time. Another issue is cryopreservation. Cryopreservation is adding to the cost. Second thing, in our locality, most people or most couples come to have their embryos in the same month because their husbands are traveling abroad. The third thing is that we last month discussed the probable disadvantages of cryofreezing in terms of increased likelihood cancer. So in 3 issues of cryofreezing, again, not all freezing systems in all centers are doing as those in the UK or in Italy. So cost much, waiting much, more harm to, not more harm, but some embryos will be degenerated in the freezing system. And last, we don't know actually what are the long-term side effects of cryofreezing embryos, especially in poor responders. Thank you very much.
Thank you, Dr.
Yeah, I can just respond to... Okay, go ahead.
دكتور محمود جهاد. دكتور محمود اتفضل. دكتور محمود اتفضل يا فندم. دكتور محمود. دكتور محمود اتفضل يا فندم.
السلام عليكم. السلام عليكم. السلام عليكم يا فندم. السلام عليكم.
وعليكم السلام.
يبدو ان في some error in my cell phone. Thank you for this interesting topic. For me, we have limited information about adult stimulation, but we have started using it. But unfortunately, we have found that the result is not encouraging. For us, till now, unfortunately, although most effort done, but our result in freezing, cryo-freezing cycles is still less than the first cycle. So for us, this is not an ideal option, especially for poor responders. It may be a better option in cancer patients, but in poor responder, we haven't it to be an ideal option. So this is my comment, and I want your feedback about this. Thank you.
Yes.
It's just a response to Dr. Tariq because he raises an issue about freezing. Let's agree that any center that offers IVF, if it does not offer a very reliable and effective cryopreservation program, they should consider that they are letting the patients down. Because what is the point of stimulating the patient to produce 12 eggs and have 7 or 8 embryos and then not utilizing all of these embryos? The answer is not to put them all at once, because that is a disaster. The answer is to put 1 or maybe 2 and freeze the rest, which is categorically clear. You will increase the cumulative chance of this couple taking a baby home using the frozen embryos. Embryo freezing is not something for us to discuss today in its principle, because it's been around since 1983. So we're talking about, good nearly 4 decades. The issue about survival is related to what kind of skill you have. Some people do not give it the attention and the respect that it deserves. I was once speaking to a very accomplished embryologist, and I asked her, which is more technically demanding, embryo biopsy or embryo vitrification? Expecting her to say embryo biopsy, of course. No, she said, there is no comparison. Vitrification is a skill and require that bit of judgment and calibration and the type and the concentration of cryoprotectant. I can only pretend, I'm not a biologist, okay? So in terms of freezing, that's not controversial. And the answer is not to abandon it. The answer is to improve it. If we have any misgiving, and without measuring what we do, we will never improve it. You can't improve what you don't measure. So when it comes to the risk of cancer, I think that is unfortunate. Really, it is unfair to freeze it. Why? Because when you look at the studies talk about there is using frozen embryos associated with increase in the risk of childhood cancer. When you look at the figure, number 1, the chance of childhood cancer is in the general population is 2 in 10,000. So it's 1 in 5,000. So if using frozen embryo doublet, it will become 1 in 2,500. It is really too insignificant to stop us using frozen embryos. That's number 1. Number 2, association does not mean causation. And the numbers that are studied in those circumstances are hardly enough to make a meaningful conclusion. I commented on the most recent paper that was published in JAMA, maybe last month or the month before. And really, it is not something that should, because the risk of the child being knocked by a bus while it's crossing the street is much higher than the risk of hepatic or childhood cancer after using frozen embryo. So that needs to be put in some perspective.
Ya'qub, they were talking about slow freezing, not even vitrification, and they experimenting the results into vitrification, which is, of course.
Dr. Ahmed Yusuf, are you going to comment on this topic?
Dr. Ahmed Yusuf.
Yes, I want to thank Dr. Mohammed Fawzi for arranging this wonderful discussion. I think it is too early to judge this protocol, because actually most of us, there is no standardization of its use. My question to Dr. Ya'qub, Dr. Hussain, and Dr. Hisham, when do you start the stimulation of the second wave after the first retrieval? I want to know when is the time of the start. Dr. Ya'qub.
What is reported? I can't claim that I have used it personally myself at all. I can't see myself jumping with excitement to use. I'm surprised at the excitement that's being given to this protocol for poor responder in the first place. But for fertility preservation, it's been recommended after you do the egg collection, you wait 4 to 5 days and start stimulation again. But there is no validation to say there are 1,000 cycles that were done when recommencing stimulation happened after 4 days, after 5 days, after 6 days, and that correlated with the results or otherwise. It is all case series more than anything else. There hasn't been any credible randomized control trial to address the merit with the outcome measure that matters to patients. Is it the disappointment of failed cycles that matter to patients and therefore they need to bank the embryos from those stem? So what's wrong with banking embryos from standard ovulation or standard stimulation? So it is really all up in the air.
Yes.
Assalamu alaikum.
Wa alaikum salam.
Many thanks, my dear professors, for this great analysis. I have a question rather than a comment. My question is, what is the impact of this DU-STEM protocol of stimulation on the synchronization of the follicles? Because if we suspect to have bigger number of asynchronized follicles, maybe we have poor quality of follicles, and this may be reflected to the success rate. What's your opinion regarding this point? Thanks.
May I answer?
Yes.
Yes, please.
Well, he has in this in Abaldi series of cases, he uses progynova or estradiol valerate from day 21 of the previous cycle, which has been shown to do more synchronization of follicles. But I totally agree with you. Synchronization maybe would apply for the first wave of follicles during follicular phase, but not, of course, in the second phase. We have faced the same problem in the 15 cases that we've tried so far, that synchronization is a problem within these cases.
Dr. Husam, can I become a bit controversial?
Of course, sir.
This synchronization business is an illusion, because if you look at in your practice, every time you do a scan on day 9, you will have follicle size 17 and follicle size 14 and follicle size 13. So we were led to believe that using GnRH agonists will make the follicles grow from 0.0. But when we see in practice is the variation in the size of the follicles. So synchronization is not the be all or end all, really. And the same with the antagonist, the same with the agonist. Otherwise, if synchronization is working beautifully, when you scan the patient on day 10, you will have 20 follicles of size 17 or 18 millimeter. It doesn't happen.
Ya'qub, what I really meant by this is that you are within synchronization of getting mature eggs. So you will not find 9 millimeter with 17 millimeter. But of course, definitely you will definitely find 12 and 13 and 14 and so on. I mean, that's basics. But maybe what they claimed that estrogen priming would lead to more synchronization, that the group would be more within the mature levels, if you want to call them this way.
Not many people using the estrogen priming. That was fashion.
For those of using short protocol, are you still using it? Yes.
Oh, good, good.
Okay, guys, we're getting into very close to the timing of closing of this session. So do anybody else would like to comment or would like to add? If I might could conclude at the end what we have found so far.
ناخد conclusion من حضراتكم، حضرتك والدكتور هشام والدكتور يعقوب.
Okay, if I start, dual stem seems to be anything that comes out to help for those who are producing less than 3 eggs would always be an addition. I do not see that dual stem will cause or will result in quite significant result, maybe an egg or 2. I think, and I ask anybody who wants to use this, please do not charge patients for it. So you can, because you only can charge patients for things that will improve definitely the outcome, and dual stem I would question seriously if it would really lead to changing of the outcome. Maybe in the context of fertility preservation or in oncological patients, they might have a role because any one egg would do the difference. So at the beginning, it's still very under research, should not get into the routine practice. And for those who would like to try it, please do not start it unless you know exactly which protocol you will use. On the same time, do not charge the patients. It doesn't seem to be that much of physiological. Yes, there is multiple waves within the follicular, within the ovarian cycle, but maybe, I'm sorry about it, maybe using luteal phase would lead to maybe 1 or 2 eggs more. If you can, and I would suggest this to all of you, if you would like to use it, why don't you do a program of 2 follicular phase stimulation rather than follicular and and late secretary and secretary phase. Maybe the learning curve would affect the results. Maybe we are not yet on the optimal protocol, but it still has to be within research context only. Thank you.
ناخد دكتور هشام وبعد كده الدكتور يعقوب. في برضه هشام في سؤال على المبعوث تكست. دكتور محمد طناحي بيقول what about the endometrium if we use this protocol double follicular stem may yield better endometrium. ده سؤال برضه حضراتكم تجاوبوا عليه في الكونكلوجن يعني.
Okay, for my conclusion, this paper is a weak paper. This is a weak meta-analysis, weak systematic review. We cannot rely on such results. For those who are advocating this technique, I may suggest only not to use antagonists in this protocol. There is no need for using antagonists at all in this protocol because we are not afraid of premature LH surge. Even if it happens, it's a poor responder. The risk of LH surge in poor responder is much less than in higher responder or in normal ovulatory patient. So don't overcost the patient with using the antagonist. Just use medications for stimulation. But again, we don't advise to use this protocol until there is a sound evidence. Thank you.
دكتور يعقوب
اتفضل.
Yes. For me, I would really, based on what I heard from you and your local experience, my plea is not to use it until we have firm evidence that it helps patients. Okay, and also for the reason I mentioned about reservation, about cryopreservation. But if you really wanted to keep the patient, not with you, but to keep the patient on track with continuation of treatment, you have the option of banking. You give the patient a package of 3 cycles where you stimulate in the follicular phase, you collect the eggs, fertilize them, and cryopreserve them at 2 p.m. stage. You give her another one, you remove the disappointment because our patients have probably relatively much higher expectation than normal. And then you need to only consider this if you have a validated cryopreservation program. And if you only counsel the right patient so that you select the group that's suitable for this exercise. Otherwise, the standard conventional stimulation with conventional decision-making that follows is absolutely fine, as long as it's done with honesty and integrity and the right setup. And if you have a case that is difficult, we all have different level of experience. Just send the patient to someone who sees more of these cases, who have better experience or longer experience, and rather than try to experiment on her without necessarily guaranteeing that you will have achieved her potential. That's my conclusion.
Thank you, Dr. يعقوب.
Thank you. أشكر دكتور حسام، دكتور هشام، دكتور يعقوب، وطبعا مستنيينكم إن شاء الله الأسبوع بعد اللي جاي في
رحت فين يا محمد؟
ده خرج. يعني على العموم it was a lovely night and lovely discussion. Thank you all.
موجود
we may not answer all your questions, but طيب اوكي. make a closing remark يا محمد. اعمل closing remark.
أنا بشكر الدكتور حسام والدكتور هشام والدكتور يعقوب على الميتنج الجميل ده، ونشكر كل الحضور، ومستنيينكم جميعا إن شاء الله في قطر ايجيبت الاسبوع بعد اللي جاي ان شاء الله باذن الله يكون ميتنج موفق بوجودكم كلكم فيه. دكتور يعقوب حابب تقول لنا حاجه على الميتنج البرنامج بتاعه السنه دي؟
الميتنج الحقيقه يعني raises the expectations and more than meets them, because from year to year it is just proving to be the right festival for scientific input and scientific contribution, and I hope it provides a good platform for improving the clarity of the concept, improving our practice, improving how we deliver the message to our patient, and learning from each other and learning from the experts from different parts of the world who you as organizing committee have made it possible. And this is something to be proud of. Unfortunately, you are becoming the victim of your own success because you have to work harder and harder and harder every year. but the hard work will be more than paid by the appreciation and the impression that you left on not the whole region, but the whole world. I've been to the British Fertility Society meeting, where it was a meeting of 3 societies: the British Fertility, the British Andrology, the British Embryology, or ACE. There was about 800 delegates. That is Great Britain, where IVF was invented. But for your meeting, you hit for 2,000 and more. If that is not success, what is? Well done.
ألف شكر يا باشا، إن شاء الله بإذن الله في انتظاركم جميعا. ألف شكر دكتور حسام.
أشوفكم على خير، مع ألف سلامة.
تصبحوا على خير.
مع السلامة يا باشا. مع السلامة.